Hi, welcome back to your prescription for medication education. My name is Yenmi, and I'm a passionate pharmacist here to bring you quality information regarding medications and health-related topics. If you've enjoyed my last couple of videos, please consider subscribing. Let me go ahead and begin. Let's break down the term sympathomimetic amine. The prefix sympatho is referring to the sympathetic nervous system, and mimetic is referring to its mimicking of activation on the sympathetic nervous system. The term amine refers to their phenethylamine-based structure, similar to amphetamine-like stimulants. The exact mechanism is unknown, but sympathomimetic amines are believed to suppress appetite by acting as indirect agonists in the central nervous system. These medications act primarily via norepinephrine, but also affect dopamine as well. The appetite suppression is believed to be due to stimulation of the hypothalamus, resulting in norepinephrine release. Because these medications resemble endogenous monoamines like norepinephrine and dopamine, this allows them to be taken up to presynaptic neurons within the paraventricular nucleus via the norepinephrine transporter. Once inside the neuron, these medications compete with norepinephrine for vesicular monoamine transporter type 2, which causes the displacement of norepinephrine from storage vesicles. When enough norepinephrine accumulates within the presynaptic cell, this causes the norepinephrine transporter to reverse directions, resulting in the release of norepinephrine into the synaptic cleft. If you remember from part 2 of my obesity video, the paraventricular nucleus is a key area within the hypothalamus for regulating satiety. Within the paraventricular nucleus, norepinephrine will then go on to predominantly act on alpha-1 adrenergic receptors to suppress eating. Examples of sympathomimetic amines include phentermine, phendimetrazine, diethylpropion, and bensphetamine. The weight loss for these medications over a period of 12 weeks is 3 to 6 kilograms greater than placebo. Side effects for these medications can include cardiac effects such as increased blood pressure, arrhythmias, acute myocardial infarctions. Central nervous system side effects include insomnia, anxiety, and psychosis. They also list primary pulmonary hypertension as a side effect, but I'll review that later. Contraindications include uncontrolled hypertension, history of cardiovascular disease such as heart failure, coronary artery disease, arrhythmias, hyperthyroidism, history of drug abuse, glaucoma, and monoamine oxidase inhibitor use within 14 days. Warnings for these medications include diabetes, seizure disorders, and Tourette syndrome. These medications are approved for their use of short-term weight management up to 12 weeks. Phentermine is available in oral capsules and tablets. The dosing depends on the formulation. The dose can range from 15 milligrams up to 37.5 milligrams per day, either taken as a single dose before breakfast, or the dose can be split with a twice-a-day regimen. Lomira is a lower dose 8 milligram formulation designed to be taken 3 times a day to target eating patterns throughout the day, which allows for flexibility in dosing. For example, if a patient is an evening binge eater, then this patient may only need to take a late afternoon 8 milligram tablet to suppress his appetite, decreasing his total daily dose to just 8 milligrams. The Lomira tablet is also scored, allowing patients to split the tablet when a full dose is not needed. Phentermine has adjusted renal dosing in patients with an estimated glomerular filtration rate between 15 to 29, and all of these medications are not recommended in pregnancy or breastfeeding. Obviously, there are simply too many drug interactions for me to cover, so I'll focus on some of the ones that have the potential to cause complications for the patient. Phentermine is by far the most common medication within this class that is dispensed. Diethylpropion's dosing is 25 milligrams 3 times a day, 1 hour before a meal, with an optional evening 4th dose. It's also available in 75 milligrams extended release formulation for once-a-day dosing, and just like phentermine, its drug interactions include monoamine oxidase inhibitors, linazolid, alkalinizing agents, and radiopharmaceuticals. Phendimetrazine and bensphetamine have similar contraindications and drug interactions, and both are class 3 controls. Phendimetrazine is a prodrug, and after it undergoes andemethylation, it is converted to phenmetrazine, which used to be its own medication but was discontinued in the 1980s because of widespread abuse. Benphetamine also undergoes andemethylation to both methamphetamine and amphetamine, which have stronger dopaminergic effects, explaining the increased risk for abuse potential from benphetamine. These medications are approved for patients with a BMI of 30 or higher or a BMI of 27 or higher with at least one obesity-related condition. It's important to remember that these medications are approved for short-term use up to 12 weeks. Let's review some of the adverse effects, warnings, contraindications, and drug interactions from my previous slides. Norepinephrine release by phentermine triggers beta-1 stimulation, which has a positive chronotropic and ionotropic effect on the heart, which can trigger arrhythmias. It can increase myocardial oxygen demand, which can provoke angina. Norepinephrine also causes vasoconstriction via alpha-1 receptor activation on vascular smooth muscle, along with increased cardiac output via beta-1 receptors, which increases overall blood pressure. This helps explain some of these side effects and why these medications are avoided in cardiovascular disease. The central nervous system's adverse effects are due to supraphysiological catecholamine signaling. A deeper explanation as to why excessive norepinephrine and dopamine release leads to anxiety, insomnia, and psychosis will be saved for a different topic, but just know that excessive supraphysiological catecholamine signaling causes inhibition of sleep-promoting nuclei, causing insomnia. Overactivation of the limbic system caused by norepinephrine leads to anxiety, and overstimulation of the mesolimbic system by dopamine can lead to drug-induced psychosis. One of the adverse effects for phentermine include primary pulmonary hypertension. The association of pulmonary arterial hypertension as an adverse effect is mostly due to use of medications that have been withdrawn from the market, which include fenfluramine and dexfenfluramine, which was caused by significant activation of 5-HT2B receptors in the lungs, leading to progressive remodeling in the pulmonary vasculature, resulting in pulmonary arterial hypertension. The risk is minimal for currently prescribed medications like phentermine, but apparently there has been at least one case report after the use of phentermine for 5 weeks. For hyperthyroidism, even in mild or untreated cases, the use of these medications can precipitate arrhythmias. Regarding the contraindications for patients with a history of substance use disorder, because these medications are structurally similar to the amphetamines, there is a potential for misuse. Even though the risk for dependency is lower, the potential for abuse cannot be ignored. The contraindication for glaucoma stems from alpha-1 mediated mydriasis, which is pupillary dilation. This causes the narrowing of the anterior chamber angle, and which can obstruct aqueous humor outflow. This obstruction increases intraocular pressure, which can lead to an acute angle closure glaucoma. There is a warning associated with these medications in patients who have diabetes. This warning is due to the potential for patients to experience hypoglycemia, especially for patients on insulin and insulin secretagogues. This occurs because of improved glycemic control from weight loss or decrease in food consumption due to decreased appetite. The symptoms of low blood sugar, such as anxiety, tremor, and palpitations, can also be mistaken to the medication by the patient instead of recognizing these symptoms as hypoglycemic effects, delaying treatment. This is why it's important for anti-diabetic medications to be adjusted accordingly throughout the treatment. These medications can also lower the seizure threshold by increasing central nervous system excitability via increases in catecholamine activity. These medications suffer from diminished returns with long-term use and tachyphylaxis, which often begins to present itself within a few weeks of therapy. Trials comparing continuous versus intermittent dosing, which was considered every other month, have found similar weight loss in both groups. Due to a lack of robust long-term data, the Endocrine Society has stated that intermittent dosing is not logical or evidence-based for the use in most patients. It's believed that the rapid loss of effect is due to depletion of neurotransmitter stores, receptor downregulation, or desensitization at adrenergic and dopaminergic synapses. This is why it's only approved for short-term use. Monoamine oxidase inhibitors prevent the breakdown of norepinephrine by monoamine oxidase A, leading to the accumulation of norepinephrine within neurons. When a patient taking an MAOI is exposed to a medication such as phentermine, a massive release of stored catecholamines causes intense blood vessel constriction, leading to high blood pressure. Although linezolid is an antibiotic, it does cause reversible, non-selective monoamine oxidase inhibition. For linezolid, at least 14 days should pass after discontinuation before starting a patient on one of these weight loss medications. Alkalinizing medications such as sodium bicarbonate, acetazolamide, and potassium citrate increase the proportion of non-ionized drug for weak bases, as is the case for these medications, which reduces the excretion via the kidneys, leading to a higher systemic concentration. Sympathomimetic agents can alter radiopharmaceutical uptake and affect diagnostic accuracy of specific nuclear medicine studies. An example is cardiac sympathetic imaging with MIBG, which is used to diagnose conditions such as heart failure and pheochromocytoma. Medications like phentermine can reduce MIBG uptake by competing with norepinephrine transporter and altering catecholamine levels, leading to false negatives or misleading results. It's recommended to discontinue these medications 1 to 3 days prior to imaging. Okay, just like last time, you can pause the video over the next couple of questions before I give out the answer. A 35-year-old woman with obesity starts fendimetrazine. 3 months later, she reports taking extra doses and feeling energized and focused when doubling the dose. Which underlying pharmacologic property of fendimetrazine contributes to the concern about misuse? The answer is A. A 44-year-old woman with obesity is started on diethylpropion extended release 75 milligrams once daily. After 6 weeks, her weight loss plateaus and she reports minimal appetite suppression despite adherence. The prescriber considers alternating months on and off diethylpropion, hoping to reduce tachyphylaxis. Which statement best reflects current understanding? The answer is B. A 52-year-old woman with a BMI of 31 and heart failure with preserved ejection fraction, uncontrolled hypertension over 165/98, and paroxysmal atrial fibrillation asks about the 8 milligram low-dose phentermine product she saw online, Lomira. Which is the most accurate counseling point? B is the answer. A 54-year-old man on linezolid for MRSA bacteremia accidentally takes a dose of phentermine. 2 hours later, he develops a pounding headache, blurry vision, and a blood pressure of 232/128. Which step in norepinephrine handling is responsible for this crisis? The answer is A. You are evaluating a 62-year-old man with obesity and idiopathic pulmonary arterial hypertension who asks about short-term phentermine because it's a non-serotonin drug. He has normal left ventricular function and no coronary artery disease. Which explanation is most accurate? The answer is C. A patient with a BMI of 32 has been taking phentermine for 9 weeks. Previously, appetite suppression was strong, but now it is almost non-existent. Weight loss has plateaued. Which integrated neuronal mechanism best explains this tachyphylaxis? The answer is C. A 38-year-old man taking phentermine undergoes a scheduled 123I MIBG scan. Results show drastically reduced cardiac uptake suggesting sympathetic denervation, but his ejection fraction and clinical status are normal. What is the most accurate mechanistic explanation? The answer is B. And that was your dose for medication education. I do hope you enjoyed today's video. If you did, please consider subscribing and leaving me some comment. I would appreciate some feedback. Did you guys enjoy the questions? I had ChatGPT generate the questions for me. Were they too easy? Were they just right? Or were they too hard? Like I said, any feedback would be appreciated. Thank you and have a great day.